at this juncture, once again, let me lay out the plan for meningitis for you. Overall, the topic in neuropathology that we're dealing with here is CNS infections. And up until this point, really all of everything we've done has been infections. Now, this is a small topic, but just to make sure we're clear. Chemical meningitis. Obviously, this is not infectious, but it behaves like your traditional meningitis caused by infections. Are we clear? So maybe iatrogenic. So therefore, maybe myelography was being done, resulting in chemical meningitis. Drug-related NSAIDs, your cotrimatoxazole, penicillin, INH, and IVIG is an important one, isn't it? There are a couple there are a couple indications in which IVIG would be recommended. What if you had a child that had, take a look at the mucus of your child and on the tongue specifically, you find it to be strawberry covered, or it looks like the skin of a strawberry. You take a look at the sclera and the conjunctiva, and they're bilaterally injected. You take a look at the skin itself, and it's a desquamating rash. There's a fever, no doubt there's a fever. And there is cervical lymphadenopathy. You put all this together, and I'm referring to Kawasaki. And in Kawasaki, your treatment of choice would be what? Management. IV immunoglobulin. Could also result, possibly, chemical meningitis. Just to make sure that you're clear, say that your patient had an intracranial dermoid tumor. What does dermoid tumor mean to you? It's one of those tumors that you've heard about before, in which instead of it being a deep type of fibromatosis, maybe perhaps this tumor, and there's a rupture resulting in meningitis type of symptoms. You've heard of craniopharyngioma, something that you could find in a child. And usually what are you thinking about in this child? Complication you're looking for is bitemporal hemanopsia. Where are you? In the sella turcica, right? What's a sella mean to you? S-E-L-L-A. It's the home of your pituitary. So when you say craniopharyngioma, your most common location and age, a child in the sella in which it's filled with, quote unquote, we call it crank oil, and therefore causing severe compression of the optic chiasm. There's every possibility that there might be a craniopharyngioma cyst that will then rupture, and when it does, it may result in meningitis-type symptoms. Clear. Let's move on. Here we have leptomeningeal carcinomatosis. Once again, not infections. Diffuse seeding of leptomeninges with metastatic tumor cells. So say that your patient had or has glioblastoma multiforme, a severe type of astrocytoma, grade 4. And what may then happen? They might seed into the leptomeninges, resulting in meningitis type of symptoms. Symptoms include your headache, altered mental status, what you can expect with a meningitis type of picture. You can also have cranial neuropathies. So what kind of cancers might you be thinking about? Now, apart from glioblastoma multiforme and seeding, what if there was metastasis from some of those other cancers that you're very comfortable with that might metastasize? And these include breast cancer, lung cancer, more so small cell lung cancer, your melanoma, medulloblastoma, think about the most common brain tumor in a child, and your neuroendocrine tumors. And these may result in what's known as leptomeningeal carcinomatosis. Allow the name to speak to you. It gives you meningitis type of symptoms, but these are not infections. These are metastatic, coming from other cancers. Diagnosis, imaging, MRI, will then show you leptomeningeal enhancement. And then, obviously, you need to do cytopathology analysis of the cerebrospinal fluid. Pretty straightforward in terms of diagnosis, but you must make sure that you keep in mind, if your patient has cancer and has meningitis type of issues, your answer choice would be leptomeningeal carcinomatosis. We'll come back to our infections again. So with our infections, we'll continue our discussion, but this time, well, spirochetes. So here, once again, what I need you to do for me is keep your spirochete separate from a mycobacteria, separate from bacterial. Granted, spirochetes and mycobacterial are bacterial, correct? However, to make sense of what's going on clinically, keep the bacterial causes that we've talked about in great detail with age groups separate from tuberculous meningitis that we talked about in great detail, and then quickly here, some of the spirochetal infections such as neurosyphilis, we have borreliosis, and leptospirosis. Let's talk about neurosyphilis. So what happens here? Usually tertiary, right? Neurosyphilis. What may happen? I close my eyes and I have lost my sense of proprioception, positive Romberg. What else may happen? Lose your touch and vibration. You're referring to your tabes dorsalis. So 15 to 40% of primary, secondary neurosyphilis patients have CSF abnormalities. It very much could result in CNS infections. Can present with dementia only. Can also present with meningitis symptoms with variable focal findings based on what part of the brain has been affected. Something that you've talked about earlier is Argyll-Robertson pupil. What happens here? So here my topic is neurosyphilis. Apart from tabes dorsalis, which is of the spinal cord, dorsal column, where are you now? Unfortunately, the neurosyphilis has migrated up into the cranial cavity and therefore resulting in a whole host of other issues. So what's Argyll-Robertson pupil? There's no direct or consensual light response, but pupils will constrict with accommodation. Make sure you know the full definition of Argyll-Robertson pupil, please, for neurosyphilis. Or you could have the facial nerve or the vestibulocochlear or the most frequent affected cranial nerves. So what does that mean to you? Well, you might have difficulty with hearing or balance, vestibulocochlear, or facial. So maybe you're looking at levator-palpebrae, maybe issues with the mouth and such, right? Neurosyphilis, now you already know what happens in great detail with microbiology of tabes dorsalis. Here I'm walking you through more details that you need to make sure that you're familiar with in terms of complications. Diagnosis, CSF, but this time what are you going to find? Elevated protein with evidence of what's the name of the organism that causes syphilis? Treponema pallidum. So what does this mean to you? Non-treponemal antigen test, RPR-VDRL, and treponemal antigen tests, and this refers to FTA-ABS, fluorescent treponemal antibody absorption test. Things that you already talked about in micro, all I'm doing here is making sure that I reinforce it. Treatment, penicillin G for about 2 weeks or so. Only of the few indications for desensitization if penicillin allergy exists. One of the few indications for desensitization. Coexisting HIV infection can change the recommendation of your management altogether. So when we start getting into our HIV-associated CNS infections, HIV changes the ball game altogether. Continue our discussion of spirochetal type of meningitis. Here we have Lyme disease. So what does Lyme disease mean to you? You begin with your patient up in New England. So there we are in northeast part of the U.S. What are you doing with your friends? Maybe you're going out and you're hunting. You're hunting for what? Oh, maybe deer. You've heard of the deer tick, and of course this brings us to our exodus. And the organism, the spirochete specifically, is the Borrelia burgdorferi. And you've heard of your target lesion. What is this called? Erythema chronicum migrans. Are we clear about all that for micro? What may happen as complications years down the road? You could have arthritis, right? Arthritis, don't forget that in rheumatology. And the Lyme disease eventually could also cause issues in the brain. We know about our exodus, erythema migrans. What does that mean to you? Target lesion. You know what a target looks like? A central area erythema surrounded by pallor with the peripheral ring of erythema. Now, our focus will be on the neurologic symptoms. Aseptic meningitis. Correct. Granted, it's bacterial, but unfortunately, we have to call this aseptic. But Dr. Raj, it's a bacteria. It's an infection. You're telling me that it's an infection, but you're calling it aseptic, correct? How many times have you heard of aseptic already? We know for a fact that it's an infection. For example, earlier, we talk about some of your aseptic type of valvular heart diseases or vegetations, or in other words, I'm referring to what's known as my valvulopathies. And sometimes that's called aseptic, but you know for a fact that there's organisms such as HASIC, right? Or what about prostatitis? There's every possibility that could be aseptic, but it still could be caused by infection. So keep that in mind. Facial nerve palsies is a huge one from neuroanatomy. Mild encephalopathy, remember, any part of the brain could be affected, both the parenchyma and polyneuropathies. Number of cranial nerves could be affected. Keep these in mind. Our topic is Lyme disease, but specifically causing infection in the brain. Treatment here, amoxicillin or doxycycline or IV ceftriaxone can be used if symptoms are quite severe.